We looked at a variety of indications for consolidation maintenance after transplant, and the field's not quite settled. Consolidation still remains a bit controversial after transplant as to whether or not it's a second transplant or some form of chemotherapy. So right now, in the US, our large randomized trial did not show a benefit to consolidation, whereas the MNO2 trial did. So now we have two different sets of data that we get to look at and compare. They're different, and I think their differences will lead to some understanding as to why we see an RVD benefit in EMNO2, whereas we don't see that in the US. It could be because no one was exposed to an IMiD until after the transplant. In the US, there are different induction regimens. In the EMNO2, they were prescribed as VCD. So I think that, again, there are differences, but what's pointed out in both studies is that high-risk patients really do need something more. And so what we were able to show in our MRD trial, PRIMeR, Jerry Hahn's the lead author on that, Ed Stadmeyer is the lead author on the Stamina trial, is that patients who are MRD negative in particular at 1 year on maintenance therapy have better outcomes, both PFS, OS. And what we're now trying to do is figure out which of those patients were low and high risk. Because my guess is that we're going to see low and standard risk patients benefiting the most from transplant maintenance, whereas patients who are higher risk based on cytogenetics will need, as I mentioned earlier, more intensification to deepen the response and maintain it. The other things we looked at were Ixazomib. Ixazomib was just recently reported in The Lancet. Thanos Dimopoulos is the first author on that, showing a benefit for Ixazomib for 2 years versus placebo. So we think that's very exciting. And whether or not we can incorporate that with Lenalidomide, or look at other options such as Daratumumab, which is currently being studied, or has completed a study in the US in the Alliance. It was a Dara-Len versus Len maintenance after a Dara induction. And so we have got lots of moving parts in terms of understanding better induction, better consolidation, better maintenance strategies long-term, incorporating risk stratification. And this is critically important because if we don't understand an early endpoint, we're going to have to keep trials open for 10 years for overall survival endpoints, which is a very long time, and the field moves ahead. So we'd like to be able to understand this more so that we can study and move on to the next opportunity in terms of understanding a new drug to better treat our patients.